Well, thank you, Deval. It's a pleasure to be here. Thank you for that introduction. And thank you to the Alumni Association for inviting me today. It's wonderful in part because this is a reunion year for me. I was working on the East Coast for many years and then happened to not be able to come in 2019, but shout out to the class of '89, 35 years. Yeah. I'm sorry we couldn't have had better weather for you today, but maybe it's a good day to stay inside and hear about artificial intelligence. So we'll talk about that. I want to start with a clinical case, a couple of examples actually. So this is a case of an 83-year-old woman who has had her aortic valve replaced, occasionally has shortness of breath. She had this chest x-ray about 18 months ago, and then recently came back for another chest x-ray and had this study, and you can see now has a large mass in the right chest. If you look back at the prior study, you'll see there's a small mass just partially behind the rib in among the pulmonary vessels that was missed on that day. And the reason I show this case is just to illustrate that if you look in the literature, about 3 or 4% of diagnostic imaging interpretations contain clinically significant errors. So we all who work in AI feel a kind of an obligation to help bring these technologies to the clinic, to the reading room, where they can help us make better decisions. Another example, this is a non-imaging example. This is a plot. On the y-axis, we have predicted survival. These are terminally ill hospice patients, and these are physicians' predictions of their survival versus actual survival. So as you can see, the physicians tend to grossly overestimate the survival of terminally ill patients. And so we built an AI algorithm here at Stanford. This is the work of Michael Gensheimer and others in radiation oncology, to look at the chart and find patients who might be eligible for hospice care, palliative care, and to notify individuals who could help them have that death that they prefer. And as a result, we've had now thousands of patients at Stanford Hospital who've benefited from this program, which is driven by an AI algorithm. So I just show those two examples to give you a sense of the possibilities. What I'd like to do today is first of all, just give you a sense of why everyone is so excited about AI right now. What is it? What happened recently? And then I'll give you some sense of work coming out of the laboratory that'll show you some of the themes that I think you'll see as AI is disseminated in medicine and in imaging in particular. Then we'll have some fun. We'll talk about ChatGPT and foundation models and how those things might affect medicine. And then I'll close with some of the challenges that we're seeing as we do this work. So this, believe it or not, neural networks got started in the 50s. This is something called the perceptron, was first published in the 50s. You can see there's some numeric inputs there on the left. And then you have some weights or some parameters inside the neural network. You do a sum of products, and then out the other side you get a number, and you can get a yes-no decision by thresholding that number. Just to give you a sense of how long I've been thinking about this, this is a paper I wrote as an undergraduate on neural networks, and I concluded that they didn't work. And actually, that was, most people agreed at the time they didn't work. And the reason they didn't work is because we really didn't have the computing power that we have today, and we didn't have the size of the training data that we have today. So the massive data sets, digital data sets that we have, and the huge compute power that we have is really part of what's made the difference. The other thing that's made the difference is something called ImageNet. So ImageNet is a database of about 14 million images scraped from the web. It was put together by a computer science professor here, Fei-Fei Li, one of my colleagues. And it contains 21,000 different types of things. So you see 800 types of birds, 900 types of trees, 150 different musical instrument types. And on the left there, you see an example of one object. This is the garden spider. And you can see that the spider is typically the dominant object in the middle of the photograph. And it's a challenging visual recognition task. So you can imagine the spider's in different orientations. It's got different backgrounds. And so the computer scientists use this every year as a kind of a contest. They would say, whose algorithm could be the best at correctly identifying the objects in these photographs? And by the way, if you're interested more in kind of how this was put together and some of the history, my colleague Feifei wrote a book recently called The Worlds I See, which I highly recommend, gives some of the background. Okay, so here are the results of those competitions over the years. These are error rates. So lower bars are better. And you can see in 2010, 2011, the error rate was over 25%. In 2012 was the first time these modern neural network methods were used, and you can see that the error rate dropped dramatically. And that year it was won by a team at the University of Toronto, Jeff Hinton's lab. You may have heard of him. He was in the news recently where he had left Google. He was in the leadership of AI at Google. The next year, everyone was using these methods, these new neural nets. And it was won by a team at NYU, led by someone named Yann LeCun, who's now the head of AI at Facebook. The next year, it was won by Google, then by Microsoft, then by teams from China and from Singapore. And you can see the error rate continues to drop, and it flattens out. At that point, one of Feifei's postdoctoral scholars said, I wonder how humans would do at this task. So he memorized all the different types of cats and dogs and instruments and all these things. And he took the test. He found his error rate was about 5%. So we're getting human-level performance out of these algorithms now. And because the error rates were flattening out, the computer scientists said, we need a more challenging task than just recognizing the single object. So they started working on something called automated captioning. So this is a photograph that was shown by Feifei at the 50th anniversary of the computer science department here at Stanford. This was in 2015. That's when I saw it. And you can see now all the boxes around the objects. This is a breakfast table. And all of the text captions are created by the algorithm automatically. So bottle of water, cup of coffee, plate of fruit, all automatic. When I saw this, I said, that's what I do as a radiologist. I look at pictures, I find things, I describe them in text. So I and many others recognize the value of these technologies applied to medicine and in particular to imaging. What's happening under the hood? Why do these techniques work so well? Well, it used to be, if I wanted to build an algorithm to detect a malignant breast lesion, I would ask a mammographer, like, what is it that makes you think about this as malignant? Is it the calcification? And then I'd go back to the lab and say, I got to build an algorithm to find calcifications. The way these work, we just feed positive and negative examples to the computer. Examples of malignant lesions, examples of benign lesions, and then we feed it to this neural network. And I love this diagram because it's got the Greek letters. So it's just math. That's all that's going on in there. It's a bunch of matrix multiplication and other math. And then out the other side, we get an answer. Is it benign? Is it malignant? And the other trick is the computer scientist figured out, how do I modify those parameters a little bit so that the algorithm is more likely to get the right answer the next time around. And through billions and billions of training tries, the algorithm gets to be very good, gets to expert performance. So what's going on under the hood? Well, for an image, so we have images. Images are essentially just matrices of numbers, of intensities, right, brightness. And through, again, that matrix math, what we get out the other side is a vector. And you can think of that vector of numbers as a way of encoding the important information that's in that image. So the way that I like to think about it, which isn't strictly true, is that each number corresponds to some feature that we might say, oh, that makes it more likely malignant, whether it's a spiculated margin or microcalcifications in the lesion or something about the size, okay? That's not exactly what it's doing because it's encoding the information in ways that humans don't really understand. That's part of the black box of it. But nevertheless, you can think of that as a way of encoding the key information that's in that image. And then we can use just regression. So we put a coefficient in front of each of those numbers. We do a sum of products, and we get something out the other side, scaled from 0 to 1. Maybe the answer is 0.79. And then we make a threshold. If it's greater than 0.6, it's a malignancy. If it's less than 0.6, it's a benign lesion. And that's all that's happening. It's a bunch of numbers, a bunch of math. And that's how we calibrate that to get the best answer that we possibly can. So as a result, we have a whole industry. So this plot shows the number of machine learning algorithms that have been cleared by the FDA each year. And you can see back in 2015, that's when I first saw that picture of the breakfast table. And then there's this rapid growth in the approval, the clearance of these algorithms. And if you look at where these algorithms are targeting, it turns out the vast majority of them are targeting radiology, more than 3/4 of them. And 85% of them are imaging. Just to give you a sense, these are the logos of the more than 100 companies who exhibited at our most recent radiology conference in Chicago in November. 30,000 plus square foot of trade show space just devoted to companies selling AI algorithms to radiologists. So this is actually an industry now. And I think we're leading the way, but this is likely to be happening in other areas as well soon. Slides seem to have gone off. Yes. So my next slide is showing essentially why is it that radiology is leading the way. And I think there are a couple reasons. One is imaging data is objective, right on time. So we're imparting some energy to tissue, to the body, and we're either through transmission or reflection, we're getting some energy back, whether it's ultrasound or radio frequency for MRI or X-rays. And so we're getting a sense of what's happening in three-dimensional space to that tissue. And that's a little different than maybe a symptom that might be described by a patient, to a physician, written in the chart. Then we have to extract or natural language process that text. So some objectivity there. We have lots of imaging data. Deval mentioned the size of our archive. It's actually grown. We now have 1.6 petabytes of radiology data. We have 3 petabytes of digital pathology data here at Stanford, growing rapidly. And then these neural networks are just very good at processing images. So we're going to talk a lot about some imaging examples today. But we're just scratching the surface. So there's been a grand total of just under 700 of these algorithms cleared by the FDA. One of my colleagues at the University of Pennsylvania looked at how many different things do we find on radiology images. And it's about 17,000 different diagnoses. And you multiply that times, you see it on X-ray. It's different on CT versus MRI versus ultrasound and so forth, the different modalities. You're into the hundreds of thousands of different possible targets for AI in medicine, in radiology and in medicine. Okay, so that's all about kind of why did everyone get so excited? Where are we now? We have this growing industry. Now I want to give you some examples, primarily from work that's going on here at Stanford, about the kinds of things that you're likely to see in AI as we go. And I just want to shout out to the center that Deval mentioned, the Center for AI in Medicine and Imaging, the Amy Center. And much of the work I'll describe here is from the faculty there. And for my own lab, I'll show, particularly when we talk about language models, some of the work of my own lab. Okay. The imaging life cycle, so radiology life cycle, just to give you a sense of how many different ways these AI algorithms can be applied. Start with test selection. So you can imagine an AI algorithm looking at the chart and calculating how likely is it that this test will be positive. Or image reconstruction. I'll show you ways in which these algorithms can make images higher resolution. So we can lower radiation dose, lower imaging times. Quality control. So often there's a technologist at the CT or MRI console. They may not recognize that due to breathing or some patient motion, the images are not of great quality. That may not be recognized until I see it a couple of hours later. Now the patient's in their car on the way home. Maybe the contrast is excreted. It creates a problem for everyone. Triage. So when I'm on call on a weekend morning like today, there might be 150 chest X-rays from the ICU waiting for me, and I would love to know which of those is more likely to have like a new pneumonia or a pneumothorax or something that needs to be treated. Bring those to the top of the list. Computer-aided detection, that would help us find that nodule that I showed you to start out. Classification, so maybe a radiologist out of his or her comfort zone. So if I'm looking at a chest X-ray and I see something in the humerus, luckily, I have a bone radiologist right down the hall, but not everyone does. So it would be nice to have an algorithm that could help with the differential diagnosis. And then communicating follow-up. So alerting us to things that are in the report that maybe should be notified or communicated in a non-routine way. So lots of places to apply this across imaging. All right, so now some examples. This is from Greg Zaharchuk's lab, one of our neuroradiologists. We do a 10% test dose in some of our perfusion studies. So you see this is an MRI, axial MRI of the brain. Non-contrast on the left, 10% contrast on the right. And we use these neural networks to create a synthetic image of what it would look like if the full dose of contrast were given. So this is a synthetic image And then to the right, you'll see that's the actual full contrast image. And you can see they're very similar. And the citation there shows not only that they look similar, but that you can actually find the same abnormalities in these enhanced images. And as a result, we're getting things like portable MRI machines and ultrasound transducers that you connect directly to a smartphone that may not have given us the quality of images that would be satisfactory, but with these enhancement techniques, it can be done. So it's reducing the cost of these devices. This is the work of Bao Do at our Palo Alto VA hospital. So he's developed algorithms that detect multiple different abnormalities in musculoskeletal X-rays. So in this pelvis X-ray on the right, it detects the degree of arthritis. It detects the presence of the prosthesis on the left, and then it uses those results to pre-fill a template. So that report on the right was drafted by the AI using a template. And if you want to see something that will save me time, I kid my residents, this is an e-resident, okay? But you know, not much of the world doesn't have residents and would love to have this. You can imagine the productivity benefits of a tool like this. This is still early, but has been used now on tens of thousands of patients at the VA. This is the work of David Ouyang, who was a cardiology fellow here. Developed an algorithm, really innovative method. This was published in Nature. I was fortunate to be a part of a very large team that built this algorithm. It had two parts. One part used very high spatial resolution data of the echo. One used high temporal resolution of the echo. And combined those two in a kind of ensemble voting at the end to calculate the ejection fraction. And you see on the right, actually, it can also do some things that we don't normally do as humans. In other words, predict gender, weight, age, and height of these patients. And then I think this is a real theme that I want to highlight, is he put this algorithm through a prospective randomized clinical trial. And the randomization was half the patients had AI calculate the ejection fraction, and half the patients had an echo tech calculate the ejection fraction. And then they looked at how often the attending cardiologist made changes to the two preliminary readings. And you can see in that first row here that there were fewer changes made to the AI's assessment than to the tech's assessment. So by that measure of accuracy, it was a more accurate way of doing things. And then obviously the sonographer took 0 time on the AI, the ones read by the AI, so big savings there. And then the cardiologist saved a little time too because fewer changes had to be made. So more accurate, saves time, a really nice prospective assessment of this AI algorithm. Another example, kind of a theme to highlight, is opportunistic screening. So this is a way that we would extract additional information from the chart, from images in this case, that you might not without an AI algorithm. So on the left, we have a gated CT of the heart. So we image the heart at the same point in the cardiac cycle, and as a result, the heart is frozen. And we see that the white dots there, which are the coronary calcium, which are not just a risk factor, but they actually are the coronary artery disease. And we do about 2 million of those a year in the United States. On the right, we have the same patient imaged around the same time for a different reason. So it might have been pneumonia, nodule follow-up, trauma, some other reason. We do 20 million of those a year in the US. And we built an algorithm that could quantify the calcium. You can see there it's smudged, right? Because the heart is moving, so the calcium is smudged. But it can figure that out and quantify the calcium and give an assessment of risk. So we, again, assess this through a randomized trial. This is the work, by the way, of Bhavik Patel in radiology, an interdisciplinary team, Fatima Rodriguez, Alex Sandhu in cardiology, David Marin, and many others. And the results of that trial were, so half the patients got usual care, just the radiology report. The other half the patients, their clinicians, their primary care doctors, and the patient were notified that they had this calcium, that they had this risk. So you've got 18 million potential patients who could be notified that they have coronary disease that they didn't know about. And what the trial showed is that if you notify them, the rate of statin use goes up to over 50% from about 7%. So potential to really save lives with this kind of opportunistic screening. Chest radiographs. So this was an algorithm built by Matt Lundgren, one of our radiologists, with our computer scientist Andrew Ng and others. Detects 14 different abnormalities on a chest X-ray. about the accuracy of an expert radiologist. And what we did is we collaborated with Intermountain Health in their urgent care. They already had an algorithm that was predicting the probability of pneumonia in urgent care. And it was using these variables on the left: age, chief complaint, vital signs, nursing assessment, you see there. The last one there is the chest x-ray, and the way they were using the results of the chest x-ray is they would wait for they would go to the radiologist's queue, they would read it, they would dictate it, then they would use natural language processing to figure out if the language there indicated presence of pneumonia or not. It took a long time. And so they heard about our pneumonia algorithm and said, why don't we just look at the pixels directly, right? Let's just do it quickly, have the algorithm compute it. And you can see this program has some quite positive results. Just by helping with this prediction of pneumonia, 38% reduction in all-cause mortality, decreased time to antibiotics by about 10 minutes, concordant prescribing of antibiotics with guidelines increased, and more patients were able to be discharged as outpatients with no change in the readmission rate. So again, good positive result of a clinical trial of one of these AI algorithms. Okay, so that's some examples of how this works or can work, and some of the themes that are emerging from the lab that I think you'll see. Now let's talk about foundation models and ChatGPT. So the term foundation model was coined here at Stanford by Percy Liang and his lab, and what it means is you train a model using what's called self-supervision, and I'll show you what that means in a minute, on a very large amount of data. So ChatGPT is trained on essentially all the text on the internet, right? And what you create is that foundation model in the center there, which knows a lot about how to generate text. It generates next word, next word, next word. And then you can adapt that model to different tasks. So ChatGPT was adapted for question answering, for example. But if you had a model that was trained on images, you might adapt it to object recognition or image captioning. Okay, so what I'm going to do now is use the name ChatGPT and different parts of the name to explain how this works under the hood, how we train these kinds of models. So the G in ChatGPT just means generative. So these models are trained to generate the next word. So you give it a sequence of words, a prompt, and it generates the next word, and then given that, it generates the next word, next word, next word. That's really fundamentally what these models do. And they're trained using, as I mentioned, pre-training using self-supervision. So what that means is the computer plays a game with itself. It says, I'm going to hide certain words from myself, and then I'm going to try to predict the missing word. So here we have shortness of breath. Good. Low grade, fever. Elementary school, teacher. She appears. This is a hard one. Anxious. Okay. So, but that, you can imagine you do this over and over again, and it gets very good at predicting the missing word or predicting the next word. And that's really how this happens over literally billions, trillions, even quadrillions of iterations. If you talk about ChatGPT, it just gets very good at language. Okay? That's the P. The T stands for transformer, which is an architecture. I won't go into details, but it was just published in 2017, so it's relatively new. And you think of it this way conceptually, that I use computer speech recognition to dictate my reports. And I'd say 10 years ago, the way that worked is you took the two words that just were spoken to try to predict the third word. So you might say right upper blank. Maybe it's quadrant, right? What's the most likely next word? This transformer allows the prediction to be made on a large number of words that came before. The reason we couldn't do that before was computational complexity. This allows you to calculate based on a large number of words and to weight the prediction based on which words are most important to predict the next word. Okay, that's the transformer. Now the chat part. So then you have this thing that's really good at generating the next word, and you can think of this as training it to have a great bedside manner. All right? So you give it a prompt, what's the meaning of life? And because these are probabilistic systems, it'll generate multiple different answers. And then you have humans rate the quality of those explanations. In fact, then what is done is they'll use the human ratings to train yet another AI to predict how a human would respond to that explanation. And then they have the two AI algorithms interact with each other to train this model to get really good at generating text that's pleasing to humans. Okay, so now the implications of this for medicine. So this is an experiment that was done at UCSD. And what they did, there's actually a group of discussion boards on the web called Reddit. You may have heard of it. It just went public last month or so. And there's a subreddit or a little discussion board called DocReddit where, believe it or not, patients can go to ask medical questions. And then doctors can go and answer their medical questions, just all anonymously. And they took these answers, and these questions rather, and they fed them to ChatGPT, as well as taking the physician answers on the web. So here's an example. A question a patient asked about, am I going to go blind following bleach being splashed in my eye? I have an irritated eye. I have a red eye. And the doctor's answer on Reddit was, it sounds like you'll be fine. You should flush the eye anytime you get a chemical or foreign body in the eye. You can also call poison control. Reasonable. Here's ChatGPT's explanation. I'm sorry to hear that you got bleach splashed in your eye. Okay. Etc. Right? Very nice, long explanation, very empathetic. Okay, then they took these explanations, blinded, and they had a panel of expert physicians rate them for the quality of the explanation. All right? And ChatGPT won. Then they rated them for empathy. ChatGPT won that too. Okay? So this just illustrates how powerful these methods can be in creating explanations that humans really like. All right? But, there's an important but. You've probably heard about these models can hallucinate. They can, or maybe that's not a great word because that's more imaging, but confabulate, right? Or make stuff up. So if they don't know the answer, they'll just pick the most likely thing, even if they're really not very sure. There are inherent limitations of the training data. So the web is a biased place. If some famous person got a disease, that disease is going to be talked about, and that may well be higher on the whatever quote differential that these algorithms might generate. So the use for decision support is somewhat suspect. They're not very good at planning, again, because they're just generating one word after the other. They're not very good at math. So those are kind of important for medicine. So really interesting to see how these will be applied in medicine. There is one area that many labs are working on. We are working on it here at Stanford as well, called retrieval augmented generation. Essentially what that does is it combines the strength of some trusted sources with this ability to generate text. So for example, it might go out and retrieve the information from the Stanford website, very useful information about a health condition, and use that to generate the explanation than just anything random from the web. Okay, so I want to tell you about the three ways that I like to think about foundation models being applied in medicine. So on the left, we have what I call small language models. So we're building something for a very specific purpose. This is a model that's going to, for example, summarize a radiology report. And we build it only for that purpose. It doesn't know how to give you the best restaurant in Shreveport, Louisiana. It can't summarize Plato's Republic, but it definitely can do that one thing very well. And then in the center there, we have generalist models that we just either use out of the box or we adapt them in some way. So ChatGPT or a model like that. And then on the right, this is something we're really excited about, is could we build our own model using very large amounts of data that's just high reliability clinical data to build a clinically focused either chatbot or some other foundation model that would work well in medicine. So it's still a research question which approach is best, but I'll tell you that our experience so far is that if you build a small language model fit for purpose, it's going to be more accurate than ChatGPT is for that. But ChatGPT will be pretty darn good. So it might be 90% versus 85 or 80%. So two things are true. If you have a lab that can build one of these things, it's better to try to build it for the purpose. If you don't, though, ChatGPT and those models are going to democratize that for a lot of other people to get a pretty good answer in those cases to, for example, summarize a report. Okay, I'm going to give you examples of each from my own lab, just to give you a sense. So this is a complicated slide. I'm going to walk you through it. This is work that I did with Pranav Rajprakar's lab at Harvard. And the boxes there, the purple, the orange, and the red boxes are all neural networks. So we have the purple network is encoding the information, like I said, in that vector. of images. And the orange vector is encoding information from text. And then the red neural network is doing a comparative task. It's saying, does this text correspond to this image? Like, is this the report for that X-ray or not? So then we feed it matched pairs and unmatched pairs. And again, it's playing a game with itself. Can I detect whether it's right or wrong, whether these are matched image text or not? And in doing that, the purple box and the orange box get really good at accurately encoding information from medical images and medical text. So that's the training. Now we give it a new image. So we give it a new X-ray it's never seen. And we use that same purple box to encode the information in that image. And then we create some artificial prompts. So the negative, a positive and a negative. So the positive prompt might be, there's pneumonia in the right lower lobe. And the negative prompt might be, there's no evidence of pneumonia. Then we encode both of those with that text encoder. And then we use that red box, that comparator, to score and say which, does the positive prompt or the negative prompt have a better match to the information in the image. So in this case, you see the score for the negative prompt is higher, 0.7. And so we would classify this X-ray as negative for pneumonia. It seems kind of magical the way this works, but I will tell you, we've looked at this, and this creates a classifier of X-rays on a variety of conditions that perform at a level of human experts when we do this. So it's a kind of a way of creating, using, again, just the data that we produce as part of clinical care, the X-ray and the report, training something that can be very good. Another way, so now we're going to shift to using these models out of the box. So you may be aware there's something called the Cures Act, which was implemented late last year, that gives patients digital access to their health information, to their test results. And I can tell you from my own family, when patients get their radiology reports, they have questions. Okay? What is a mild intrasubstance degeneration of the posterior horn of the medial meniscus? Please, and is it dangerous? And so what we do is we had built in the lab an algorithm that can extract concepts from radiology reports, and then we feed those to ChatGPT and say, please explain this in the language of a fifth grader. And we get these very nice explanations with analogies to cushions and pillows, and a really good explanation for the concept. And by the way, we could do this in a different language or at a different reading level if we wanted to customize it to individual patients. So this is one of the ways that we are experimenting with these language models out of the box to help kind of engage with our patients and help them engage with their own test results. And by the way, we've done an assessment. We looked at hundreds of those and found that, again, the issue of confabulation doesn't come up, that there really aren't dangerous explanations that come up based on the way that we've structured the prompts. Okay, so how would you use these language models in medicine? We talked about explanations for patients, doctor-patient communication. So Stanford is experimenting with something that an AI listens to the conversation between a patient and physician and automatically drafts the note. That's visit documentation. Doctor-patient communication is about the in-basket messages from patients and automatically drafting a reply. We're also experimenting with that. Record summarization, a lot of labs working on that. No products of yet, but I would love that, right? If I'm reading chest x-rays, I look at 100 in a morning, and I don't have time to go through the chart on each one, but if I had a nice 3-line summary of that patient, that'd be extremely valuable. And then decision support, I put a little asterisk there just because we were talking about earlier, it's about the training data and whether these out-of-the-box models will really work well, have the right prevalences of disease. It's still an open question. Lastly, on the far right there, we talked about what if we created a foundation model with just medical data. So I took a look at the size of the training data that was used to create one of these models inside medicine and outside medicine. So this is for text. The largest text medical model is called Gatortron, was trained on 82 billion words. GPT-4, which is the basis of ChatGPT, it's not exactly known, but it's estimated to be about 13 trillion words. Imaging is the same. So there's something called RadImageNet, trained on 16 million images. DALL-E, which is one of these models that creates images from text, these fantastic pictures, trained on 6 billion images. And you look, this is a log scale. So it's like a 100x difference in the size of training data between medical and non-medical. But if you just took the data from Stanford, we could substantially close that gap. So that's something that we're doing now. We are looking at what's the best way for us to train a foundation model on the images, the 1.6 petabytes of images, and the corresponding radiology reports to create a model that might be have the same in ChatGPT moment kind of that we would create, that would have the same potentially unexpected positive behaviors that ChatGPT and these other models have had, but it would be very good at the kinds of decisions we make for clinical medicine. All right, so that's foundation models. Now I want to just talk for a minute about the challenges, and then we'll close. So first of all, I want to draw your attention to something called Raise Health. This is a new initiative at Stanford. You can use the QR code in the upper right there to sign up for the mailing list. This is a joint initiative between Stanford Medicine and Stanford Institute for Human-Centered AI, or HI. It's co-led by our dean, Lloyd Miner, and Fei-Fei Li, who I mentioned earlier, who's the co-director at HI. And it's intended to guide the responsible use of AI. So how do we make sure that these are ethical, that these models are ethical, that they're fair, and they don't disrupt our processes of care in ways that are undesirable across biomedical, both research, education, and patient care. So Raise Health. I love this framework that was published. It talks about the risks of bias and unfairness that can creep in as we develop these models, from problem selection all the way through to deployment and post-deployment. I don't have time to cover each of these, but I'll just sample a few things to talk about. So first, let's talk about data. Right? The big difference for these models now, and the biggest bottleneck we have, is where is the training data going to come from, and how do we create well-prepared training data? So you remember ImageNet. I told you about that earlier. ImageNet images are 224 pixels by 224 pixels. And there are, I mentioned these other models on the web. You can say, show me a hippopotamus in a lily pond in the style of Van Gogh, and you might get an image that looks like this. 1024 by 1024. Of course, that's about the size of a CT slice. But when we do a CT, we have many slices, and that's just the pre-contrast images. Then we have the dynamic contrast. We have the post-contrast. We have to compare to 6 months ago. We have to correlate it to the data that's elsewhere in the chart, other kinds of data. So this raises a whole host of really interesting research questions that aren't being focused on outside of medicine. So we work on these every day. And we've taken that to heart, too. Our lab, or our center, the Amy Center, has released now 20 AI-ready data sets for the world. Any non-commercial purpose, people can download them. They can use them to train models and make their models better. But even that's really not enough. We took a look at where do the data sets come from that have been used to train the AI models that are available today in imaging. And we found that the vast majority of them, this was published in JAMA in 2020, the vast majority come from just 3 states, California, New York, and Massachusetts. So we're not necessarily getting models that have the right answer for our entire population. So one answer to that is something I'm very privileged to be involved in, called Medical Imaging and Data Resource Center. This was funded by COVID money through the National Institutes of Health to create a repository of images of COVID, and now we've since branched out to many other conditions. You can see, because we collected data from all across the country, now the data matches. This is just one example of ethnicity, but it matches the census much more closely. So if we use this kind of training data to produce our models, we're more likely to get answers that are fair and get the right answer across the board. Okay, so that's data, some of the issues with data collection. Main message there is we need to think about data collection at the very beginning. If you start thinking about bias at the end, and then you're trading off equity versus accuracy, it's never a good situation. So we try to think about collecting the right data in the front end. Outcome definition. So I want to tell you the story of the first algorithm we ever built in our lab. This was led by David Larson, one of our radiologists. And the example is bone age. So we take an X-ray of a child's hand. The child is suspected of having delayed development. And you look at the cartilage in the wrist and the hand bones, and you can get a sense of their physiologic age. And the way you do that is you compare to this atlas called Grulich and Pyle, which, by the way, happens to be the best-selling book in the history of Stanford University Press. because every radiologist needs this book, and you flip through it and you find an image that looks similar to the one that you're looking at, and and they say, oh, that's a reference image for 7.5 years old. Okay, this patient must be 7.5 years old. Physiologic age, right? So we thought this would be a good algorithm for an AI. It's a good process for an AI algorithm to address. And so we built that algorithm. We tested it against radiologists. And here, lower bars are better. So we're looking at the distance from the right answer. And you can see that the algorithm is about the same as a couple of radiologists, a little better than a couple of radiologists. So human level performance, we looked at where is the algorithm looking. It's looking at the joints and the wrist. That's exactly what we would expect. So that's all good. And we ran it through a clinical trial. So we did 2,000 or so studies interpreted by 90 different radiologists from 6 centers. And we found, sure enough, it's improving the radiologist's results. So the open dots there are the control. And again, we're reducing the distance from the right answer, those orange dots. So the radiologists are getting better when they use this algorithm. Say, what? That sounds great. What a great story. Well, it turns out that the data in the Grulich and Pyle book was generated from 300 white children who grew up in Cleveland in the 1950s. And we know that there are racial differences in bone growth. And so I think if we did this experiment today, we would be thinking much more carefully about what are we testing against and what are the data that we need to collect on the front end to make sure that the algorithm is getting the right answer for all of our patients. All right, lastly, something about post-deployment. So these are different than other medical products in that they are depending on the data. And so if the data shifts that you're feeding to these algorithms, the performance of the algorithm can also shift. One example I wanted to call out is something called automation bias. This is a mammography example. So the 3 bars here, the red bars are residents, the blue bars are fellows, and the gray bars are attendings, so different levels of experience. On the left, we have what happens when the AI algorithm gives them the right answer, and you can see the accuracy is quite high, quite good. And on the right, you see what happens when the algorithm gives them the wrong answer. And you can see that predominantly affects the accuracy and depresses the accuracy of the least experienced. And so there's a tendency for less experienced practitioners to believe the algorithm even when it's incorrect. And there's other research to show that if then you take the algorithm away, that some of those trainees have learned the incorrect approach to diagnosing and that deficit is retained even when the algorithm is no longer there. So we need to, there's a lot of work to be done on what's the optimal way that these algorithms interact with their human partners. We know that the combination of human and AI is going to be better than either one alone. They have different strengths, but still thinking about exactly this interaction is a very important area of research. And then lastly, just talking about this algorithm reliability over time. So if we buy a new imaging device, it may have a different noise profile. Our algorithms may not work as well. If we open a new clinic with a different disease mix or different demographic mix, that may affect the accuracy of the algorithm and the new disease. So that pneumonia algorithm I mentioned that was in a clinical trial at Intermountain Health, when COVID came, we had to completely retrain it because pneumonia looked different and it didn't perform well any longer. So we have to be alert to all of those things. And these algorithms really need to be monitored as they work periodically to make sure they continue to work on day 100 the same way they worked on day 1. All right, with that, I'll just close with this. This is a tweet that I made from my couch in 2017. It's kind of taken on a life of its own, but I think it's a good message to leave you with. Will AI replace radiologists? The answer is no, but radiologists who use AI will replace radiologists who don't. And I think you could replace the radiologists here with physicians. I think that we're going to use these tools as partners. So I'm really excited. I'm glad that I was able to tell you today a little bit about what the future might look like. I'm very excited about this future and to be working in this area. I thank you for your attention and look forward to answering your questions. There are microphones around the room, so if you have questions, raise your hand. We'll bring you the mic so that the people online can hear you. Yes?
Hi. Looking to the future in clinical medicine, if you have something where through history, physical, and laboratory work, you have come to a differential diagnosis, say 3 or 4 different things. How do you go about, what information do you use to develop an algorithm to help you answer the question of what is the diagnosis here?
Yeah. Well, in that case, what we would need is, so that's a great question, and it's really more complicated than any algorithm is today, right? So today we're talking about diagnosing pneumonia from one chest x-ray or diagnosing diabetes from information in the chart, the lab values and so forth. But what we're working on is what you're describing is more of multimodal AI, where we're taking all the information we have, whether it's genomics, whether it's wearables, whether it's imaging, whether it's EHR data. And so you would need training data, right? So you might pre-train it using a foundation model. So that's what I would want to do is let's take all the data we have at Stanford, just using a self-supervision approach, get it very good at understanding information from all those sources, and then fine-tune it using, or adapt it using specific data where you would know what the differential or the diagnosis is, and you have the data that for that patient. And again, through multiple tries, and it may get the answer right or wrong, but it's going to adjust the parameters, and ultimately it would be able to generate a differential or even a guess at the top diagnosis for that patient. But that, I would say, is still a ways away because with the complexity of our data, it's taking us longer to build those comprehensive types of algorithms. And I still think, by the way, that having human physician as in the loop, consuming that information from the AI, interpreting it, deciding whether it's leading it astray or not is going to be incredibly important. Yeah. Yes?
Have you taken the opportunity to retrospectively look at some of your X-ray diagnostic reports and see how many mistakes, both significant and insignificant mistakes, there are, you find with the AI that, and then of course have a person compare the importance and the correctness?
Yeah. So we've done some work, actually with the startup I did. One of the things that it could do is analyze reports and, for example, find women with prostate glands, men with uterus, those kinds of things that aren't likely to be true, or right-left, where it's left kidney in the body of the report, right kidney in the impression of the report, those kinds of things. And then, of course, the literature that I mentioned, which is 3 to 4% of these reports contain errors. That's not against AI, but it's just against kind of audits of these kinds of things. So as a radiologist, yes, I do confess that we have a significant error rate. But to take your point, I think one of the ways these AI methods would be very useful is to do these kinds of, let's say today when we audit the performance of a radiologist or even a technologist, we're taking a small sample of cases because it's just, it's a human review of that. And maybe even the prevalence of disease is going to be low within that sample. So it's just very hard to do. But you could build an AI that could look at everything, right, and pull out the ones that are maybe more likely, then have a human review that, and then filter it down to some cases. And you'd have a kind of peer learning system driven by AI that would be very powerful. Yeah. Yes?
Oh, thank you for such a illuminating talk and explaining the use of artificial intelligence. So my question is, what do you see, what would you suggest in the practical implementation of the use of artificial intelligence for clerical, responsibilities of the practitioner? Because, you see patients 8, 9, 10 hours, and then you spend another 3 to 4 hours dealing with the charting, the work queue, and the billing. And there are lots of companies out there. How do you decide which one to use and which one is? Because, we're interviewing.
Right. I would say this is the biggest gap we have in AI today. So I showed you that slide of the 100 logos of those companies. Radiologists are really, I think, puzzled today with that same question. How do we know that this algorithm is going to work for us? There are a couple things you can do. One, more information about the training data. So was the model trained on data that looks like your patient's. It's really the same process we go through. You're reading an article in the New England Journal about a new pharmaceutical, and it looks like it has a great effect, and you may want to use it in your patients. And one of the first sections there is always about the demographics of the people who are enrolled in the trial, and you look at that and say, well, is that like my patients or not? And that's sort of the same role that the training data plays in AI, is how do we assess whether this model was trained with data that's like my patients. Today, we don't get a lot of good transparency about that. And we certainly don't have transparency when it comes to ChatGPT and some of these models. They won't share exactly what the training data is. So that's one answer, not a great answer. And then the other is also kind of a conundrum, which is how do you tell that these big language models are working? And we in the lab are trying to build these benchmarks so that we can just tell, are we making progress or not? Sometimes that's a little bit difficult distinction to make. I guess my answer today is that most practices ought to be doing some kind of a small study on their own data with their own, in this case, maybe their own doctors and patients, and to see, is it really working? And that's why we did a pilot here at Stanford on those kinds of technologies and found there were certain kinds of clinics that it worked better for than others. Yeah. Yes?
I just wanted to comment. It seems to me that pattern recognition seems to be a kind of a guide in where we're seeing AI. So for example, in oncology, IBM Watson and their attempt to do oncology failed, and that certainly threw AI backwards somewhat. But I wonder if you might comment the areas in medicine, like it seems like radiology is going to be valuable. I would guess pathology and any other insights you might have to that pattern recognition. So I think AI will be an awesome tool. I don't think it's yet ready to to replace decision making in a complex scenario.
Yeah. First, just about the Watson experience. I think what that showed, first of all, I was amazed watching Jeopardy. That inspired me. But it showed that a model that's built to win Jeopardy isn't necessarily built to give oncology advice. That's a big leap, right? Just in terms of the structure of it, the back end of it and so forth. That's a big leap. And I think now we've learned more about how to do that, and so I think we're starting to make progress in that area. Yes, so imaging, I think, is going to continue to lead the way. It's objective data. It's lots of data. Within imaging, I think the use cases in pathology are actually even more compelling than radiology. They have a lot of use cases that are like, find me the one cancer cell in this lymph node, and they're spinning the wheels on the microscope and trying to find that, and you could just imagine that AI just could help draw attention to high probability areas, or quantify the number of nuclei that have some feature. Again, counting things, that's just in the wheelhouse of AI. So some of those are very compelling. I think in radiology, screening is an area where we might even see physician out of the loop. So maybe 80 years ago, if you got a potassium value, you'd have some pathologist with test tubes and the droppers and so forth. And now we have machines that do that, right? And the pathologist is responsible for quality control on that machine. And there's some really good simulation research to show that if you take some of the mammograms that are so likely to be normal and shunt them to no human review and have the humans focus on the ones that are more likely to be normal, that actually ends up being, that system of care ends up being more accurate than just having the humans review them alone. So that's an area. In healthcare, I would just say as a general matter, I think the AI developers need to listen more to the physicians and all caregivers, nurses, aides, technologists. What are the things that they need and that are going to help them do their job more efficiently, more effectively? In radiology, we're just getting to that point. We've had a lot of algorithms like, I can find lung nodules for you. Well, if you have a lot of false positives, that's just going to slow me down. I'm tracking down all these markers, and is it really positive? And I'm not sure that it's really helping. So I guess I would use that would be my general principle, is let's think about the workflow, the change in efficiency, and some of the, not so much differential diagnosis, but just help me document what I'm doing, and some of the nighttime work that we end up doing. Yeah. Yes?
You showed initially, well, at one point, a map where most of the training data comes from California. And,
Yeah.
But maybe that's not so bad because the training data comes from well-trained physicians, right? What happens when the training, well, I know this because my husband, who got the degree here about messing, he was telling me, no, but of course it's well-trained. But then when I showed him the data about other physicians who had misdiagnosis, mistreatment, he was flabbergasted. So that does happen in the rest of the country. So what happens when these other doctors start injecting their data into the thing? You get garbage in, garbage out. And you think it might be self-correcting, but it's not, because they might miscategorize a death due to a different reason than the one that they had missed in the first place. So how do you protect it from garbage in, garbage out?
First, I'm not sure I agree with your assumption. Okay. I mean, I would say there are often different types of patients in those areas. So yes, probably the data are more likely to come from tertiary, quaternary places. But those are, that doesn't mean those data are going to get the right answer for a place that treats primarily primary care. So that's, I guess, one approach. The other thing I would say about these is we need to make a distinction between the training data and the test data. So when we train an algorithm, for example, to recognize pneumonia, we'll go through and we'll build an algorithm that just goes through the reports and finds, which ones mention pneumonia in a positive light. And that algorithm to process the reports might be, let's say, 90%, 95% accuracy, but it's not perfect. But these algorithms are fairly robust to training data that has mistakes in it. But on the other hand, when we test it, so we want to know exactly how accurate it is, then we'll create maybe 200 or 300 cases that we have multiple experts look at. We are ironclad. We know those are truly the right answer, and then that's how we measure the performance. So anyway, that's a couple of answers to that question. But I think that we need to consider that there just are a diversity of care settings, and the answer might be different in different settings, just certainly in terms of the prevalence of disease, for one. Yes?
Hello? Oh,
Hi.
Hi, Dr. Kurt. I'm Dr. Stephanie Lowry-Nacuzzi.
Oh, my goodness. So Stephanie was my across-the-hall neighbor in my freshman dorm.
So I want everybody to know that at one time, Kurt had a mop of dark, curly, long hair.
Yes.
So
a lot more hair, a lot
Yes.
less gray. Yes.
we're all getting gray. Well, thank you for a wonderful presentation. And my question is regarding the data sets. Is it better to have the composite, which includes by sex and racial, a mix that better reflects the population, or have separate algorithms? This is the algorithm that chest X-rays for women versus men, or you know what I'm saying?
Yes,
Should it all be composite or separate composites?
It's a great
Thank
question. And we actually, I don't know the answer to that question. I think it's a very interesting research question. As these models get bigger, you could say, well, if you just have a huge model with a huge diversity of data, it probably is going to get the right answer for everyone. But there may be some diseases that are more rare, or there are some subgroups that are just very small, and it might not get the answer for those. And so you may need to enrich the data in those groups. There was a really interesting paper that just came out of Google DeepMind in the last week or so, showing that you can actually create synthetic data. So that, remember I showed you that picture of the hippopotamus in the lily pond? You can ask those models, show me a chest X-ray. And it turns out, our lab has done this, and it looks kind of like a chest X-ray, but not very realistic. But you can retrain them with lots of chest X-rays and lots of reports. And then, our lab has generated this technology. You say, show me a chest X-ray with a small right pleural effusion, and it'll create that for you. Then you can take that synthetic data and add it to the real data, and it actually improves the performance of the model and improves its performance on more diverse data sets. So you could actually supplement data for those smaller groups and have better performance across the board, using that synthetic approach. Yes?
Thank you for the innovative talk. I was particularly impressed that empathy the AI had higher score
Yeah.
than human. But changing a gear a little bit,
Yeah.
practically speaking, could you please make some comments about the future training of radiology residency? Do you think we need fewer number? What are your thoughts?
First, a comment about the empathy. That isn't totally a fair comparison, obviously, right? If you had a physician talking to his or her own patient in an exam room, that would be very different than flying by on the internet. So I'm not sure that's totally fair, but nevertheless, it does give you a sense of how compelling these models can be. With respect to the training question, I think that's another major gap. So I'll tell you a story. I'm old enough, when I was a resident, MRI first came out. And we, as residents, had to learn about the physics of MRI and kind of how these machines worked. There's a frequency encoding direction of the image. There's a phase encoding direction. What that means is if there's flow in something, it'll create these phase echoes across the image. And if one of those circles from the aorta ends up on the liver, it looks a lot like a liver lesion. And so you need to know something about how this device works in order to predict or to know about its failings, to know when it's leading us astray, right? And I think that same principle applies to AI. I think we're all going to have to learn a lot more. That's kind of what I've tried to do today a little bit, is to tell you a little bit about how they work so you can understand how they might be leading us astray. And I think everybody needs that training, from medical students, residents, all the way up to the most senior attending physicians really need to, as these technologies are implemented, need to learn more about how they work. We're just at the start of that. This man needs a microphone. There's someone here? Yeah.
Jerry Thrush, School of Medicine, 88. Thank you again for the great presentation. At the beginning of the presentation, you walked us through, given the example of a chest radiograph with a mass, with large data sets, transformers, vector calculation, and ultimately a binary response, the presence or absence of a mass. Yet, many radiology reports have a non-binary response. For example, prominent hilum could be a mass. Well, having read these reports forever, do you see the AI-generated responses remaining binary, which are certainly most helpful to clinicians, or slipping into some kind of a gray zone? Could be a mass, could be a prominent hilum, might be atelectasis. What do you think about the direction?
So when I train the residents, I talk about the difference between vagueness and uncertainty. Okay, vagueness is bad. Uncertainty is inherent in what we do. So, if there's a nodule on the chest X-ray, you might not know, is that a cancer or is it not? But you should try to explicitly describe your level of uncertainty. Is it true? Is it false? Is it something in between? And so, yes, I think that would be ideal. That is an area of active research. There's something called explainable AI. Number one is, can the AI give you some rationale for why it said what it said? Something about, in this case, maybe the features of that nodule. I think it's malignant because X, Y, or Z. Or can it provide not just an assessment, this is a nodule, this is not a nodule, or this is cancer, not cancer, but how likely? It's like, how certain are you of that judgment? I think that's what we do as humans. So yeah, two answers. One, radiologists need to be a little more crisp and describe our uncertainty rather than using kind of hedge vague language. And two, I think that these models ultimately will need to, I think, to be the most effective. We talked at the end about human and machine interaction. I think to make that interaction ideal, it would be best if the machine could express its own uncertainty. Like, this one definitely is a cancer. This one, I'm not so sure. And people are working on that, but that's relatively new.
So you see a certainty score associated with it. For example, hilar mass, certainty score 90.
Right. I don't know if we can get that quantitative, but maybe we could put it into a few categories. Yeah.
Great talk. Yeah.
Last question.
Yeah.
Okay.
Mine is probably the craziest. Hallucinations and truth. I think patients are going to want to Google and say, should I take a COVID vaccine? Or who won the election, or whatever. But do you see AI being able to become a guardian for truth? And how do we protect ourselves against hallucinations and confabulations, or whatever term you use?
Right. Well, so to start, let's talk about sort of these GPT models that are out of the box, trained on everything. today, patients might Google their diagnosis or their symptoms and find some information from the web. Some of it might be reliable, some of it might be not reliable. And I think generally people are now aware that when you Google something, that the list of links, some of them are good and some of them are not so good. I think that, ChatGPT, for example, or these other language models are trained on the entire web. And so they have the same information base, if you will, but because they are trained to be so smooth in the way they present it, they perhaps are more persuasive or more believable in the way they present the information. So I think, again, there's an education issue there in that the people who use these systems need to understand that you may have heard the stories of the lawyer who had the brief with the citations at the end that were totally made up. And that's because it said, well, for this issue, who is the most famous person who talked about this issue? Well, that'll be the first author. And what's the most famous journal? Oh, that'll be the journal. And it just made some things up. And so you need to understand the weaknesses of these systems to make sure that you fall prey to them. And I think there'll be a phase probably where patients probably have more trust in these systems than they should compared to maybe when they Google something, and that's something we'll have to deal with as physicians. The second thing I would argue is that we may be less susceptible to that if we start training foundation models on real clinical data. But that, to me, is still an open question. That's what we're really excited about, is could we eliminate some of those problems by training on real data? Yeah. Thank you for your attention today. Look forward to being with you today.